Welcome everybody to Stockholm Psychiatry Lectures. My name is Clara Hellner Gumpert and I will be your chair this afternoon. I'm also director of Center for Psykiatriforskning or Center for Psychiatry Research here in Stockholm. It's a collaborative organization between KI and Stockholm County Council. Stockholm Psychiatry Lectures have been going on for several years and we've had 24 lectures so far. You can watch them or you can join the followers on Facebook or you can watch them over YouTube. And as you see, we have quite a few number of followers and the majority of them are actually from outside Sweden. This afternoon, the theme will be, can psychotherapy invent a serial killer? We have 4 speakers, myself, Professor Gerhard Andersson från Linköpings universitet, Linköping University and Karolinska Institutet, journalist Dan Josefsson, and also Professor Richard McNally from Harvard University in the United States. I'd like to just say a few words about the lecture. As you see from the theme or the title, this lecture or this afternoon is supposed to deal with psychological treatment and the possible adverse effect of such treatment. The focus is not whether or not someone has been guilty of crimes or whether or not the legal process has been done in the right ways. Those types of discussions are handled elsewhere, so the focus is psychology and psychiatry. Okay, so we'll start with our first speaker, Gerhard.
Nice to see so many people here. Welcome. And thanks for inviting me to be one of the speakers here. Yeah, and Clara already introduced me, so I'll just start. I want to do this. I want to provide you with a brief background to the idea, notion that psychological treatments can have negative, unwanted effects. I wanted to elaborate a little bit on definitions, what is sort of known, and I would not feel comfortable as a researcher if I would not bring some data with me, so I will give you some empirical findings. And then I will try to answer the first question here you saw. Can psychological treatments have side effects? Briefly, well, just so you know, it's nice so many people are here, but this is really not a new area. It's been well established and known and written about that indeed anything that is effective might have some side effects as well. And that's, but it sort of had a boost a few years back here. I think sort of one of the driving things were Scott Lilienfeld here, who wrote a paper on psychological treatments that can cause harm. And you know see from the title here that it is obviously something that implies that there are treatments that can be harmful. And then there was a series of papers in American Psychologist by one of them was by Dave Barlow, who again reminded us of the history of the idea of negative side effects. So continuing here, what is a side effect? But it's kind of tricky because we very often in therapy deal with conditions that have a natural course. People can get worse, they can get better just by themselves without any intervention. And it all sort of depends on where we start from. In a very good paper by Steve Holland and Sona Demidian, they really described this very well, that we can indeed have harmful effect. We can also be in a situation we have no treatment effect, and hopefully, and that's where we're in this business for, we can have a beneficial effect. And I will return to that. Because it's most likely a majority of cases treated with psychological treatments experience some benefit from it. But it's important to say that a harmful effect is not just nothing happens, in many cases at least, that's the thing. So it should be more than a natural course, or at least, or should be more than an absence of an effect. There are some useless thing or perhaps not so helpful therapy approaches or techniques that might not lead to anything, but indeed they are perhaps not so harmful then. But it can, and I will return to that, be the prevention of spontaneous improvement by having a treatment and then you won't improve as you would have done if you didn't have that treatment. So quickly here, I think it's been estimated that around 5 to 10% perhaps do in therapy experience some side effects, unwanted side effects, or at least deteriorate. And when it comes to certain areas, it might be around 5 to 10%, like for drug treatments. And that's kind of a ballpark. Michael Lambert, who's a prestigious psychotherapy researcher who's good at guessing, he estimated these figures, and he estimated the proportion of specific effects of specific therapy techniques, and that was quite small as well. And there's a lot of non-specific effects, things going on in therapy, was his argument, and he might be right. I just put 4 pictures here on the slide, one being actually critical incident debriefing. Perhaps Rich will tell us a bit more about that. I don't know. McNally, who's been working and writing stuff about that. Another thing is drug treatment, and this long-term psychological treatments, psychoanalysis for whom we don't know exactly, because many of these treatments have not been scrutinized in controlled trials, but even so, it's potential. And then we have, I didn't find a picture to illustrate exposure therapy, so I found one on virtual reality exposure therapy. There's a lot, and that's that thing in the corner here. Well, in order to say that something is really a negative side effect or a side effect, we need to see there is some kind of causal relationship, and I think it can be sort of a good idea to think about how we talk about drugs. We know that a usual painkiller, paracetamol, can be quite dangerous if you have too many of them. It's obviously lethal, and in rare cases, it can actually be dangerous even in small doses. And we know that we have this information. But then we have cancer drugs, who are by definition very often lead to side effects. And there are some other things going on in therapy if you compare to other things, like if you go online and learn how to manufacture a bomb and then do it. That's obvious side effects of the internet. Or things that go on in religious cults or in sects and stuff like that. So we need to sort of think, what are we talking about here? Well, perhaps some therapies are almost like cancer drugs. They come with side effects. Many therapies are perhaps more like paracetamol. It's rarely that you see these major side effects, but who knows? And talking about side effects, I think it's important to sort of take in account as well if this is something that interact with other treatments or other events in a person's life. An example would be someone who's very agoraphobic, won't dare to go out, and then go out and get beaten or killed. Is that a side effect? Well, it wouldn't have happened without the therapy, but it's an interaction, a therapy effect in interaction with a bad environment, perhaps. And it's interesting to think as well what happens in therapy on a larger scale or on a smaller scale. It could be that some things we say or do in therapy, and I'm a practicing therapist myself, some of the things you do might not be so good. And there's actually a literature on this, how you resolve or sort of repair when things go wrong within a therapy session. And that's quite useful, I think, for the future. But then there are more larger scale effects of possible negative effects. Another thing that's been written about is the duration of the side effects. If it's something that goes, I didn't feel so well for one day, could be worth it. Or it changed my life, and I've been thinking about this for many, many years now. It's ruined my life. Not so good. So the duration of the effects, and there's fairly little written about on that particular angle as well. And then we have this no pain, no gain. All of us who've been doing exposure therapy, it is some pain, otherwise it's not exposure, but it's the promise of gain. And then we have this important thing about consent. Exposing, I always say that, said for a number of years, exposing someone to something they don't know why they should do it, that's very close to a trauma. Whereas if you perfectly understand or are prepared, that's psychological treatment. Right. And then surprisingly little has been mentioned about what's been large literature on placebo effects. And I'm admit as a practicing therapist that some of the things I do is a belief effect that could be described as placebo, a positive thing, things happening in the brain as well. So, but we also have the opposite concept of nocebo, where you start to believe certain things and that is bad for you. This is nice, right? Anyone feeling a little bit hungry now? A fruit bowl? This is perhaps how many of us perceive therapy. A nice, warm person listening to you, understanding you. But we talk about with the information that one of these guys or his friends just passed the bowl 2 minutes ago and just ran away and you know that this has been full of these creatures. It's not so nice. It will give it a bad name. And perhaps this could be an option that we know from a start that we need to scratch some things off the surface here. And so that's, on a more serious note, I think it's not, it's a controversial thing how much we should describe the side effects. If they are rare, of course we should inform about them, but if we overstate it, that can be a problem as well. Yeah. So what is there to do? Of course, as a researcher, this is what we always say. Measure, perhaps even on a weekly basis. That's an interesting development in therapy research, that you can get quite a lot of information if you measure on a weekly basis, and you can perhaps change your therapy or adjust it depending on the outcome. That's increasingly the case. And report it, that's another thing. And of course, try to understand it. Otherwise it won't make no sense. And the guys who were writing about this are all in agreement that we both need experimental studies, randomized controlled trials and so forth, understanding of mechanisms, but also case reports that are left out sometimes, and perhaps using qualitative methods that go more into depth what people really experience when they have a side effect of a therapy. And another thing is when we do therapy trials, and I've been responsible for quite a number of those, we are very keen on measuring outcomes in terms of symptoms, but we rarely measure the possible negative effects related to the therapy that they received. So that's something we can learn from. And some people have been proposed some measures for that. Right, and here's a sad thing. I tried to do this years back. I had this patient there's actually a combination, it's a case report. This patient who had experienced a negative effect from a previous treatment. That's another thing, right? Negative effects from a previous treatment, and nothing whatsoever happened in terms of outcome. And it didn't make me famous. It's been cited 3 times, and I was one of them who cited it. Right. But there are other people who might be more successful. This is a brand new review study, and I really like this approach. It's by Ulf Jonsson and his friends. What they did, a very clever thing, they did a literature search and found all the randomized controlled trial from the year 2010, and then the properly controlled randomized trials, 132 of them, and out of those they checked whether they had any reports of harm. And as you see here, around 20% had that. 4 of them described adverse events. 4 trials reported adverse event, but in a complete manner. 4 trials reported that they had no adverse events. And 15 trials reported some kind of deterioration. I think that's kind of a difference. If people are not feeling better than when they enter the trial, that's not necessarily an effect of the therapy. So that's very encouraging. But the even more encouraging good news, speaking about citations and impact, is that the journal papers who reported negative outcomes had managed to get published in better journals. That's a good sign, right? It's an encouragement for us researchers to report our outcomes, negative outcomes, and get published in better journals. I thought it was the other way around, actually, but I was happy to see that. Another thing is internet interventions. I've been lucky to work with some loads of people doing online internet interventions. It's something we're pretty good at here in Sweden, I might say. And so in collaboration with Per Karlbring here, a close co-worker, and his postdoc from Germany, we sort of dived into our large data sets and one study looking at side effects in internet-based, actually combined treatment for social anxiety disorders. And Per, I think I'm jumping to conclusion now when it comes to acceptance of a particular paper, but who cares? Right, so what was the outcome briefly? Well, 133 individuals were diagnosed with social anxiety disorder. This was an 11-week treatment, actually two-step treatment, beginning with bias modification training and then online CBT. Looking at side effects here, if I got it correctly now, 4 described side effects of the attention bias modification, which by the way has not worked so well in our hands. I don't know why, but that's the thing. And 7 reported negative events that they related to the treatment. And 2 people independently coded these responses, and people were explicitly asked about negative effects. And then emergence of new symptoms was the most common thing. Deterioration and of social anxiety symptoms and negative well-being was another thing. And in most cases was a temporary effect. So here's an example of what someone might say, which is not perhaps so untypical of some treatments. You know, you become more aware of things that you haven't thought about. If you have social anxiety disorder, you might learn a lot about how you self-focus, and then you might start to self-focus in a different way even if you didn't do it before. So this is one example. Another example here is someone who has experienced some sleep problems, but they're quite rare. Another example is a patient-level meta-analysis. We've been in the position that we collaborate across research groups in the world. This is a fairly new therapy approach. We get all the data sets in, and we can look at individual cases to see if there are any sign of deterioration. This is not as good as the previous example, because here we just look at deterioration. But it was fairly rare. A small percentage, much smaller than 10%, less smaller than 5%, showed signs of deterioration. And actually, being in the active treatment was meant that you had less deterioration than being in the control conditions. So that's, you know, when you get these numbers, it becomes a little bit more convincing than the often very small studies that we have. Okay. A little bit, 1 minute over my time. I will just conclude now by answering. But as a psychologist, of course, I give you 5 answers instead of 1. Are there side effects? Yes, of course, there are. But they may be rare, fairly rare. They may be transient, or sometimes even trivial. Yes, and they can indeed be more severe. I'm sure we will hear more about that today after my talk here. Some of them might not be possible to avoid, like some be feeling uncomfortable when it comes to exposure therapy. It might be a little bit better if you have some pill that makes it a bit smoother, tuberculosis pill, who knows? But more or less, some of the things we do can be sort of perceived as negative, but not as, yeah. And should we report this? Of course we should. And in the interest of everyone, I think, as much as we can, we should do our best to avoid negative effects. If there's an easier way to do exposure therapy that leads to less adverse events, of course we should do that if we maintain the same level of efficacy. I'm sure most people would agree on that. In particular, if there's some potential gain involved. And by that, I would like to end.